So welcome everyone. My name is Barbara Bechter. I'm an associate professor in human resource management at the Faculty of Business and co-director of the Wolfson Research Institute for Health and Wellbeing. And I would like to welcome you all to this public lecture. Today we have two speakers, Martyn Griffin. He is a senior lecturer in organization studies at Sheffield University Management School, and Peter Hamilton. He's associate professor in human resource management at Durham University, also the Faculty of Business. And they will talk today about an ongoing project focused on critical care nursing during COVID-19 pandemic. The paper is based on data collected in interviews with more than 50 critical care nurses across the UK and across a 12 months period during the pandemic. It's based on an ongoing project, and the project team is working on very interesting research topics and areas such as emotional labor in critical care, media representations of nurses, critical care as a liminal space, critical care as an evolving profession, and of course, practical lessons for critical care from the pandemic. Today's presentation focuses on moral distress and critical care. The topic of the presentation Martyn has chosen is running towards the bullets, moral injury in critical care nursing in the COVID-19 pandemic. So I will stop here so that we have time to listen to the presentation and hand over to Martyn.
Thank you so much, Barbara. Thank you for the invitation. It's really great to be here. And I'm going to be talking mostly today. I think Peter did the last presentation, so I'm going to be delivering the presentation today. So just to give a bit of background about the study, where did it come from? It actually emerged from about the middle of 2019, so before the pandemic, at the Academy of Management conference in Boston. And me and Peter have been giving the papers separately across Boston that day, and we come together during the evening to basically discuss how the day's activities have gone and have an update on our sort of academic careers so far. My partner Lisa, who's an ICU nurse, joined us for the evening to catch up as well. And the conversation began with me and Peter, saying how our papers had gone and saying how badly we'd had papers rejected in recent times and funding woes and such forth. Before we could bore our guest anymore to tears, we so what is it like to work for you in an ICU ward on a day-to-day basis? We said, well, before we came, a typical day was we came in one day and basically in the morning we had a road traffic accident where we lost a young man, and then in the afternoon we lost a mother of two, and we spent the afternoon comforting her and the young man's grieving parents essentially, and really trying to take care of these people. And it really shook us quite starkly at that point straight away. The difference in stakes in these two professions couldn't be any more stark. I was sort of moaning about the paper rejections to this day-to-day struggle with life and death. And this really points towards this quote at the bottom of the first slide here, which goes as follows: although 1 in 5 of you admitted will eventually die in an intensive care unit, many of you won't even know what that is. The public awareness around what ICU is quite low in general, and that points towards nursing in general. We still have, the general public still tends to have this view of nurses as this sort of lady with the lamp, sort of gliding, Florence Nightingale gliding from bed to bed as this angelic figure, when the real sort of story of ICU in particular and nursing more generally is a lot messier. As we see on this picture on the right hand side, machines everywhere. Anyone who's been on an ICU ward will know how sort of how many machines are about, how chaotic it can feel at times, where these people are very calm, but you're looking at them going, wow, this is a lot messier than I imagined it would be. So we spoke a little bit about this, and Peter's sister actually was an ICU nurse for a number of years as well. He had common experiences of how scary this was in terms of her repeating her own experiences, and we decided it would be interesting perhaps to look at this field through an organisational studies lens. That we'd looked at the literature after that and the days after, and there was very little written about the ICU more specifically. There's a lot on nursing more generally, but very little on the ICU. So I sent an email to the British Association of Critical Care Nurses, and I managed to have a meeting with Nikki Credland, who's a fantastic woman, and agreed to join the actual study. And she said, yes, let's do some research on it. So we got a team together and brought them together and decided to do some interviews with critical care nurses through a sort of organisational studies lens. Unfortunately, the pandemic then began, and we thought, well, now's not the appropriate time to do this research. It's really not. They're very busy. But the more it went on, we thought, actually, now is the exact right time to be doing this research. As they're sort of not being listened to, we could perhaps give them the voice to talk about their experiences in a number of different ways. So we decided to go ahead with it. So the presentation today is really about the findings from this research project over the past couple of years. It's based on a full paper that we're about to give in Vienna, in the medical and humanities sort of stream over there, which is the same title paper. And the paper's almost complete now. It's about to go off to a journal in the next couple of weeks. But this is the general sort of structure of the presentation today. I'm going to take around 40 minutes. I think in total you'll have about 15 to 20 minutes to ask some questions, which will really welcome any critical comment or insights that you have on this. So just to provide some context, and I'm not going to go into great detail here because I'm giving a presentation of the Wolfson Insitute. I'm sure you guys know a lot of this already, but the ICU, the foundations of this come out in the 1950s, actually a different epidemic at the time, the polio epidemic, where the need for people to manually ventilate patients in iron lungs at the time were being paid like very low wages to basically manually ventilate patients for hours upon end. And this became the birth of ICU care, intensive care over periods of time within a hospital, over many days. And this obviously exploded also due to increased coronary care requirement and increases in medical care capacity in the post-war period. Today, in the UK, we're talking about 30 million people being treated worldwide and 200,000 in the UK. Well, I think that's gone up since the pandemic. And the basic sort of foundation of critical care is essentially one-on-one nurse to patient ratio. So essentially a patient having their own nurse. And there's various components of this, of having a high knowledge of the machinery around the patient, of being able to administer the right drugs, of actually having high levels of patient care, but your patient's often sedated. So a lot of your care actually comes around dealing with families and either grieving families or families hoping their loved one gets better, but also being very good within teams of professionals of multiple disciplines coming together to try and throw everything at a patient to save their lives. And as one critical care nurse said about what it takes to be a critical care nurse, it takes critical thinking, almost a bit of perfectionism, a strong work ethic, attention to detail, and that drive to keep pushing, even when you're exhausted, to keep pushing. So within this profession, before the pandemic, there were high levels of stress and burnout. Around 1/3 of ICU nurses reporting a burnout over the course of their career. An incredibly stressful environment, as you can imagine, to be in on a day-to-day basis. And then the pandemic obviously came along and made this sort of working environment even more difficult. As critical care nurse once suggested, it was this alien thing that was coming to attack us, and we were on the front line. And also we all know the sort of start of this pandemic began in sort of March 11th, 2020. And we've got this quote here from the European Centre for Disease Prevention and Control, the risk of healthcare system capacity being exceeded in the EU and EEA and the UK in the coming weeks are considered very high. So this was obviously a very scary situation on ICU wards in particular, where they were worried, obviously, about this influx of new patients, but obviously starting from a very low base as well in the UK. There was already a difficult situation about bed levels. I think it was about 7 beds per 100,000 people at that time. That's compared to the EU average around 16 beds. And I think Germany's up towards 25, 26. So that puts it in perspective. We're already in a really difficult position in the UK. And staff levels are notoriously low within the NHS at the time and in ICU wards. So there was a real fear there about how are we going to cope with this? Now, the main reaction of the government and the NHS was obviously to postpone routine surgery. So lots of people had delays in their operations, as we know. But importantly, also the redeployment of staff around the hospitals. So bringing in people who perhaps have never worked on ICU wards before. And then we'll come to that later about how difficult that was. So the pandemic and the effects on ICU nursing was immediately an overwhelmed system, as Harris puts it. This sharp increase in nurse to patient ratios, it got up towards 1 to 3, 1 to 4, and in some cases there's reports of 1 to 6 on an ICU ward, which is absolutely insane in terms of being used to look after 1-to-1 patient care to go to 1 to 6. You can imagine how difficult that must have been. And there was a real general palpable fear, as some already recent research has shown, about being safe on these wards, of actual patient safe, but also nurses feeling safety for themselves as they sort of had high working hours and a lack of PPE, as we've seen widely reported on the news. Now, a really fantastic survey that was brought out in 2021 by Greenberg and colleagues, summarised the effect this had on the ICU ward. So 45% of surveyed staff met the threshold for probable clinical significance on at least one of the following measures: severe depression, PTSD, severe anxiety, etc. And people were even thinking about self-harm and suicide, which is obviously a massively worrying thing in the health profession, particularly in ICU wards. And this wasn't just within the UK, and we've got multiple studies now that have come out in China, Italy, France, saying exactly the same things. People were facing awful situations on ICU wards. So there were calls within the literature early on to actually provide a deeper understanding of ICU nurses during the pandemic, which we felt buoyed by in terms of what we could offer from our perspective. Now, we decided, once we'd looked at the literature and actually thought about our findings, that one of the most interesting ways to try and understand the experience of ICU nurses was through the concept of moral injury. So moral injury, as we've got a definition, is a deep emotional wound that is unique to those who bear witness to intense human suffering and cruelty. So initially it had been used by Shea. So he had introduced the concept in the 90s to describe the experience of war veterans who had basically been put into situations where they'd witnessed pretty horrific things and been sent into war zones and to experience intense suffering and cruelty essentially on a regular basis, and come back feeling these feelings of what he described as moral injury. And he suggested there needs to be three things for this to actually be present. So it has to be a betrayal of what's considered right by somebody who holds legitimate authority and in a high stakes situation. All three of those things need to be present for it to be considered a moral injury. So in various sorts of approaches here, we're looking for morally injurious events where sort of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations exist. So for a soldier, I suppose it would be being sent into a war zone without the right equipment, or being sent in and witnessing people die when you perhaps shouldn't have been sent into with a vast number of troops against you. So people coming back from war zones, feeling sort of this, deeply held grudge against people who've been felt betrayed by people who sent them into dangerous situations without the right support and guidance. Now, recently, this concept of moral injury is brought into other professions. So police officers have started to been written about in this terms of moral injury, of experiencing it. Journalists and child protection officers perhaps been going to people's homes in great poverty and not being able to remove children, perhaps because of budget cuts and so forth, and difficulties around that. So there's a lot been written about moral injury in healthcare research in recent times. So these have mostly been written in relation to sort of serious mental health problems and depression and PTSD being related to this experience of it. Feelings of shame and guilt, and even physical pain being experienced because of moral injury. So during the pandemic, there were calls, there were very short papers in the British Medical Journal, I think, calling to actually take seriously the experiences of ICU nurses and ICU professionals, experiences of moral injury, that this was a real problem, something that was going to come to the fore. There's been one small study on moral injury in healthcare more broadly in the NHS, which wasn't focused on the ICU ward, but that found senses of betrayal and abandonment within this setting. But there are limited studies on moral injury, which we felt it really opened a door for us to ask this question: how did ICU nurses experience moral injury during the COVID-19 pandemic? And that's the key core research question for this particular approach. So on to the methodology of the study. So it was a longitudinal study. We decided that it would be best to try and interview these nurses throughout the pandemic over a course of time to see how their experiences changed. So the first phase took part in September 2020, where we had 54 critical care nurses. And then in January 2021, which was during the second peak, I think, particularly difficult time, where it went down to around 38 nurses. And obviously we expected some attrition in nurses. It was a very difficult time, we understood if people didn't feel like repeating these interviews, because they were very difficult interviews at times. And then the final phase of the interview was in June 2021, where we looked back at, it was coming towards more of a lull, but people were starting to experience a lot of these problems in full as they started to take a breath and really, understand what was going on. This took place, across people within 38 different hospitals. So it was spread out around the whole of the UK. There was two people in Ireland, actually, two nurses in Ireland. These were extended interviews, really long ones, went into depth, especially during the first phase. Some were lasting up to nearly 2 hours. They were very emotional interviews, or usually one nurse or even the interviewers coming to tears during them. So we have regular debriefing meetings after each. Every Friday we'd meet and talk about our experiences and the nurses' experiences in particular, and try to work through these and take notes and begin to work through the data already. By the end of it, we had around 7,000 minutes of data, and we had 6 broad topics of focus, which Barbara mentioned at the beginning, which each one of us took the lead on. And this is the one that I was taking the lead on. I think Peter's taken the lead on the Clap for Carers one, which is also a fantastic paper, which will be completed soon and submitted. It's at the sort of same stage of our development with those. And we basically then move into trying to understand how moral injury would be understood within these settings, asking what experiences the nurse have, what are the implications of that, and how do they cope with the moral injury, and then importantly, how is the institutions reacting to that? So we're going to work through those 4. I'm going to try and focus now for the rest of the presentation on those areas in the last 20 minutes. So what were the experiences of moral injury by ICU nurses? I'm going to use 4 examples from the pandemic to work through this. Now, one of the most serious examples of moral injury experience was unsafe staffing levels. One nurse suggested straight away, the critical care nurse number 2 suggested it was like some kind of war zone. It was incredibly dangerous and incredibly stressful. Even already, there was lots of evocations of war zones. Like this come up unprovoked. That's why the title of the paper itself is Running Towards the Bullets, as we'll come to a bit later. But as nurses were suggesting, we were taking 1 to 5, 1 to 6 patients per nurse. So obviously having 6 patients on a ventilator, we're only supposed to have 1, just completely throws you off guard in that sense that you feel like, how could I possibly provide the same level of care to 1 patient that I normally do on a working basis to 6 people? To do that was almost like you felt like risk every day. You were constantly worried that you were making mistakes. And another nurse, we were looking after too many patients. We were doubling up, tripling up sometimes, looking after 3 times as many people as you would do normally. And then you add in the fact that the sickest that you've ever looked after. It was just absolute madness. So this sort of unsafe staffing levels was a breeding ground for moral injury. People felt, how do we end up in this situation? We knew we were understaffed. We knew we didn't have enough people here. And that bred this sense of an ethical transgression from the very beginning, and a betrayal almost. As another nurse suggested, it was just unsafe. That place was unsafe, so working there was actually quite stressful. Now, obviously, we know that redeployed nurses were brought in from other parts of the hospital, which all the nurses suggested was that, they were thankful of these nurses being redeployed. But also, there was a real sense that a lot of them were untrained and almost being thrown into a place which they didn't know almost anything about them largely, and became a hindrance on some occasion. As one nurse suggested, he was correcting all their mistakes basically and looking after them in the sense that some of them were really, really helpful and really got on with it, and some of them were outright dangerous. They wouldn't listen to you and just kind of did their own thing. That was incredibly stressful. And another nurse, so people are pissed off, and they don't know if they're pissed off with COVID or the actual trust, because we feel let down by the trust just as we feel let down by the government. So it's a massive shortage of staff. They knew this was going to happen. Nothing was in place to prevent that. They just said, get on with it. So that already this sense of betrayal by someone in a position of authority left them in this scenario and left them to get on with it in a situation where they find it incredibly difficult. On top of this, there was also a lack of support by senior staff, a sort of betrayal of what's right by someone who holds legitimate authority, to go back to that original thing. And this came through with a really strong theme within the findings. As one nurse said, completely abandoned. Honestly, that's the only word I can describe it with, abandoned by the senior team. It was awful. And another nurse, there's a real anger in a lot of us because we feel struggling more, we're getting more exhausted, and yet we sort of think, hang on, why am I flogging myself when these people, senior nurses, are never out of the office? And then they tell us, we understand, our door's always open. Come and talk to us. We're all in this together. More and more of us are thinking, well, no, we're not, are we? We're not in this together. You've never been on the unit in full PPE for hours on end. You've never dealt with the relatives. You've never dealt with the distressed patients. We feel like we're just sort of almost pawns that are just being sent down the pit. This really came through, this idea of not having enough support by senior staff, finding themselves in these high stakes situations and then being left to get on with it. And as another nurse suggests, feeling like cannon fodder. So what happened, the medics wouldn't come into the COVID group and then they would phone you in order to do the handover. So there's a real sense of really being thrown in at the deep end, and a surprising finding that a lot of the actual doctors were actually refusing to come into areas where the COVID was rife, the dirty zones as they were called. And that was really quite surprising. And so the third experience of moral injury found as a major theme here was inadequate equipment to provide good care. So this, obviously, this thing of sort of a lack of adequate PPE, which was well known within the media at the time, but also, quite surprisingly, running out of key medicines, having to sort of substitute medicines for others in a dangerous way sometimes, and actually running out of oxygen within some hospitals, which was repeated a number of times, which was obviously quite scary for a number of nurses trying to provide adequate care within these. So as one nurse said, we're being asked to double our risk pretty much by putting contaminated gowns back on. And that came from one nurse who was asked to sort of shower down the gown and then put it back on in between going out for toilet breaks, which was amazing for her to hear that, you know, it's such a dangerous thing to do. And really, in the end, I think they refused to do it. And a lot of nurses experience this scarring and pressure damage, which we've seen the famous pictures on their faces of the sort of, being on so tight the PPE that it's left pressure damage. A lot of the girls still have scars on their noses, as critical care nurse 10 suggested. Others describe wearing PPE for 13 hours. It's like being in a desert with no water. And another nurse talking about this idea of going to the toilet, which, not being able to, because obviously if you took some PPE off, you went to the toilet, that was gone. And then you had to put new PPE on, and it simply wasn't available to do that so much. So as one nurse said, a human right to be able to go and get a drink or go and have a wee, isn't it? Yeah, but nurses hold their bladders until they can't do it anymore. And this idea of real sort of, struggling on despite, feeling that can't possibly be right to be doing our jobs in this situation, and being pushed to the limits without the adequate equipment and without the adequate capacity to actually do their jobs properly. And the final sense of moral injury here that nurses were experiencing was being unable to give patients a dignified death. A real key part of ICU care is really sort of being able to do that and to actually give a good death to their patients. But time and time again, nurses were talking about having to flog their patients. This was a word which was new to me and to most of the interviewees. But this came up regularly. So as one nurse said, you flog people and then you ought to be looking after them thinking, we all know they're not going to manage, they're not going to survive this, but they're not quite at this stage yet that on paper we can withdraw, let them die. But we know that we are going to ultimately do it. There's no real satisfaction. It's not a very satisfying job to know that you're just keeping somebody going and that ultimately you'll be withdrawing treatment on them in a few days. So this came up time and time again, that nurses were finding it extremely difficult to be told to flog patients, to throw medicines at them, to try and save them, when they knew that actual palliative care, actually a route out of there, was perhaps a better way forward for that patient. And this really struck them as a sense of moral injury, of really being told to do something which felt against their ethical foundations of their job, of what they would usually do. The other one I'd just like to quickly mention is patients dying without families at their bedside, and nurses having to view this was a really difficult thing for them, which wasn't really, they were used to having to care for a patient through their families. But as one nurse said, not having the families at the bedside for the end of life, that was really difficult. So it's, for all intents and purposes, it was the nurse holding the hand and stroking the forehead. We facilitated a virtual end of life if the family wanted that, or you would have rang the family. What do you want us to tell your loved ones? What is the most important messages that you want to give them? And we will be whispering that into the patient's ears. And another nurse, she just gave me a load of audio WhatsApp messages for me to play to his ear, which I did for 3 days before he died. I feel like that really affected me. And this came up regularly from multiple nurses as heart-wrenching, horrific, morally wrong, quite importantly, and horrendous, as a real sort of imposition on what their actual profession was there to do, to give this good death. And it had been ripped away from them, from people above them, above their pay grade, essentially telling them how to behave within their ICU unit, and was really felt as a sense of moral injury on a day-to-day basis. So just to sort of summarize here, this idea of sort of moral injury and relating it back to a battlefield comes directly from the nurses themselves. That was what influenced this focus on moral injury. So as one nurse said, it was almost like a battlefield. I personally don't know what it feels like, so I don't want to be flippant with that term at all, but it felt like a war zone and like we were running to stand still, running towards the bullets, as another nurse put it. And a lot of nurses have changed their sort of outlook on how they viewed nursing. As one nurse put it, it changed the way I view nursing. So many things went on that you would never ever see or do or accept that went on. So this really strikes again this sort of sense of ethical transgression that went on within these wards over time, and the impact it had on these nurses. And the final quote I'd like to quickly mention is the sense that they've just been left there by, you know, by these people in higher positions and by the general public in general, as Critical Care Nurse 33 suggests. It feels like the rest of the world's moving on and they're all happy, and the poor ICU nurses are just stuck in this horrible, never-ending kind of nightmare. And that was towards the end of the phases, where they felt they were just, you know, they were still having to deal with these patients day after day after day. There was no recognition anymore. The claps had stopped, as Peter would explain later, and they were just being forced to get on with this. So now on to the implications of moral injury on the ICU. You know, what were we seeing? What were we hearing as? What were we finding as the implications of having to go through these experiences on a day-to-day basis, not just as one-off experiences, as often moral injury is, but, you know, multiple moral injuries, day after day after day. And it was incredible to see what were the implications of this. So emotional burden was the main theme we found here, one of the main themes. So as one nurse puts it, you're seeing nurses, you're seeing them fall into bits. You know, people walked off the unit, people just sat and cried. And another nurse, I basically spent the whole night shift walking around crying. I just did all my work. Fortunately, my patients weren't really conscious enough to see me, but I just spent the whole night walking around, doing my jobs, crying. And the implications, emotional burdens, didn't just stop on the ICU wards. They actually extended to these nurses' everyday lives. So we heard multiple accounts of nurses crying after shifts and really finding it difficult to cope with their families and in day-to-day situations on the tube, hearing loud noises beeping and going off. One nurse put this quite frankly, she suggested, I went for a run to the park and I was running and I started to feel like a rising pressure in my head, like something was rising. It was mainly anger, but I don't know what I was angry of. I felt something very intense rising over a few minutes and I had to stop the run and I went into absolute hysterical mode. I was hysterical and I don't even know at the time what the hell is going on in my brain. I thought I'd lost it. I thought I'd lost my mind. I had to stop running and it was just hysterical crying in the middle of a park. And I couldn't calm it down. It felt like the brain was on fire. It was like kind of on fire. And there was a million thoughts at the same time. I don't even know what was the main theme. I think it was anger. And this anger was really palpable from what they'd been through, what they'd been subjected to, these repeated moral injuries outside of their own control, ethical transgressions that they weren't able to change as they went through their day-to-day workplace. The second main theme was psychological burdens, the idea of flashbacks being experienced by nurses, which were quite common within the findings as well. So as one nurse puts it, you have these visions you can't even get rid of. I said to my colleagues, how many ghosts can there be in your head? These people are dead and I'm still carrying them around. And another nurse who actually felt sort of the physical reaction of this trauma that she said he couldn't leave behind. And it lasted for 3 days constantly. It was actually shaking for 3 days, constantly having the flashes of my dying patients. And these were quite regular findings of nurses' experiences of waking up in the middle of the night and shouting about work-related things that were happening to them. They couldn't escape the workplace. Even when they went home, they were experiencing flashbacks to that workplace where that moral injury had occurred in quite devastating fashion. Now, the implications of this upon mental health within the ICU units was profound. Obviously, we've seen the statistics, but these are the words, the actual stories beneath those statistics, which we really want to give a voice to within our findings and within our research. And as one nurse puts it, you know, in a senior role, I think it definitely feels like across the board, not just on my personal point of view, but my colleagues, everybody's really sort of at the end of their rope, really, in terms of being able to cope with the stress. And as one nurse puts it in really quite upsetting sense, it would upset me to see some of the nurses. One girl kept tapping her head so strongly, it was so bad. She was in a state with herself, and to watch her, she was looking at me eye to eye, just trying to stop crying. You could actually taste the atmosphere, you could slice it, you could just slice it. It was awful, it was awful. Anyway, yeah, the end of my career, love, laughs. And that gallows humour coming through there, you know, that was repeated time and time again, people almost having to laugh, otherwise they would cry at the sense of how awful it was on those wards. And then more severe cases of health implications. We heard that quite a lot, you know, as one nurse put it. I know a lot of my colleagues have been off work. They've all gone, you know, they've all got PTSD. And we heard this regularly of people having these serious problems. And the most serious account of mental health deterioration we heard was from one nurse who had experienced really bad, so she'd had no prior mental health conditions before the pandemic began, but throughout it she'd had some really bad experiences of deaths and losing patients, and like a lot of nurses had. And she explained, I experienced more nightmares and flashbacks about my patients. I was sectioned twice over the summer and there was section 2. And she'd been sectioned because of her experiences of dealing with ICU care, having to go to work and then essentially having a child taking off her because she had to be sectioned over a period of time during that summer. And her story, which we will tell at length in another publication, it was really quite upsetting to hear, having a devastating effect of this care in the ICU. Now, the other major implication we found here, all these things they've been through, it's not surprising. There's a huge intention to leave, max exodus of staff, as we heard it, within the profession. As one nurse put it, I've actually handed my notice in, whereas I would probably have gone on until I was 60. I just think, no, I'm going to do it now. And as another nurse suggested, these weren't people just leaving to go to, do other nursing jobs. These were people actually leaving to start businesses like dog walking. One of them was going to work in a supermarket. People leaving this profession just because they could not cope with the levels of as we've framed it, moral injury that were occurring and were likely to be ongoing at the time of interviewing over a number of times. So to move on to the coping mechanisms for moral injury, what do people do to try and cope with it? One of the major things that ICU nurses, try to do was, as they put it, sucking it up, burying your head in the sand. It was almost quite worrying to not have the psychological safety to say they're not managing. It was almost seen as an ICU nurse to be tough, to really battle on, put your head down and get on with it. Other people spoke about alcohol as an escape, and friends and family. Others sought out counselling on an individual level. They went to charities and tried to get help in that sense. But the problem we found within this about the actions taken or lack of action taken was that a lot of the response was individualised, particularly in phase 1 and 2 of the response. As hospitals were busy with the pandemic, they left the ICU nurses to cope with this themselves, and there was very little psychological care in the early days of it, when they needed it most, when all the damage, the moral injury, was being done at its height. There was some psychotherapy support, so we did see some instances of psychologists being brought onto wards, but there was others where they said there was no sort of support to anyone psychologically, which was quite worrying. And another said, the psychologist, I never saw a psychologist, never met one, never had a phone call, never was given a number. Despite the knowledge of what was going on these wards, there was an abrogation of responsibility there to these nurses and their well-being, particularly during the early phases of the pandemic. And as one nurse, who was the woman who was sectioned, put it, which was really quite worrying. The first time I was sectioned, I was put on the waiting list for CBT, and I was took off the second time I was sectioned. So I'm still on the waiting list. I've contacted work and I've contacted the head of nursing as well, and I know quite well. And they can't push me up the waiting list at all. So even someone who was sectioned because of their experiences with moral injury during the pandemic, trying to save other people's lives, wasn't considered a possibility to push up the list to try and improve her, a life and a psychological well-being. It was actually quite amazing to us to find within our study. And the problems with this is just the lack of availability and the difficulty of access. A lot of these nurses were being offered care, during their shifts or right after their shifts, and to go off and cry perhaps about their experiences and expect to come back and treat patients was just unthinkable to a lot of them. So they didn't go and take up on the small amount of help that they were being offered. And they were just disappointed from here on about how they were being supported, a lack of support from up the hierarchy in these early days, and a poor amount of communication. They really felt, one of the key things we found was debriefing, a call for more debriefing at the end of shifts about what everyone had been through mentally with their patients. And this just simply didn't exist enough during the sort of madness of the pandemic. People weren't debriefing, or very few amounts of debriefs during shifts. So they were almost being left to get on with it themselves. And now that the psychological care was coming, it was almost too late. So what are the contributions to the study? I'm just going to run through these for the last 5 minutes, which is good timing. So what we hope to have shown during this study, and I've run through a sort of whistle-stop tour of it there slightly, even in the 40 minutes, is that this moral injury faced within this study shows a cumulative nature of moral injury. It's not just a one-off accounts of it, which might have occurred before the pandemic, of course, and they will occur in the future. But these were ethical transgressions that were multiplied and laying on top of each other. And this sense of really experiencing this way was quite profound. And there was a real need we believe as a contribution, there's a real need to verbalise and share awareness of moral injury on ICU so that nurses themselves know they're not alone in how they're feeling these different ways, and they can come together collectively to discuss these things, to work through them. We also talked slightly about the longitudinal effects of moral injury, how it developed over the course of the pandemic and had this effect on mental health deteriorating over time, and the drastic need, we believe, to improve psychological care for nurses, particularly ICU nurses, who are going into these situations where moral injury is being faced. They need some route to moral repair, otherwise they're always being thrown to the wolves every time they go on a shift. So really, we hope our study contributes a real sort of a shot in the arm for government and policy organisers to really, lift this. We know that there's already been progression in this area to some degree, but we would encourage even more to really make sure these people who are putting their lives on the line get the psychological care that they really deserve and need. We also tried to draw out within the discussion part of this paper the intersubjective dimensions of moral injury. Really trying to move beyond this individualistic understanding of, intrapsychic, it's just something you experience by yourself. No, it's something you experience with others and through others, collectively over time as a profession. I think there's this sort of profession who has gone through this collective experience of moral injury. And we really feel that really could push the community to talk about moral injury as a collective, to really try and work through that and to understand how it can be worked through and understood more deeply. But more importantly, I suppose this final one is to understand the dimensions of power, and the ICU nurses really did feel quite powerless in these situations. They were dominated. They were expected to go to work. They couldn't just run out halfway through their shift, although some redeployed nurses had to because they felt so scared we heard during the interviews. But a lot of the ICU nurses, that's what they signed up to do. Like soldiers, they've been put into this war zone and expecting to push on and do it. So we really feel that this, really needs to push the government to manage the susceptibility to moral injury by reducing, understaffing, under-resourcing, really trying to fix the problems that are more likely to lead to moral injury. We don't expect there to ever to be a silver bullet where, nurses and health professionals never experience moral injury, but we do expect it to minimise the chance of this happening by preparing properly and to then provide the routes to moral repair that are really necessary for them to get better over time. And just the concluding thoughts here, as we look at these faces of these men and women who really went through this on ICU, as Griffin et al., this isn't me, Griffin, this is another very good Griffin. Psychological treatment of the morally injured is not a substitute for social mobilisation to understand and address moral injury. So really just, putting a sticking plaster over these things is not good enough. Healing them after it's happened is not enough. We really need to focus on funding health properly so that we don't end up with these people being in such difficult situations psychologically and emotionally, perhaps in future pandemics, but in normal times when they're also asked to do amazing things for us so that we can go about our lives and hope that if we are unfortunate enough to be hurt badly, that we're actually cared for properly by people who are in the right frame of mind to do it. So thank you very much for listening, and me and Peter will be happy to answer any questions now.